Hey everybody, welcome back. It's good to be back. I'm Braden Paul, and this is the Generalist CCFP 105 Topics podcast. We've got a great episode for you today. This is the ever-present loss of consciousness.
What a beautiful voice to hear again. That is the familiar Braden Paul coming out of Port Alberni right now. He's in the St. Paul's EM program, kicking ass and taking names, and we're looking forward to having him in the workforce when he's done.
Absolutely. Couldn't avoid the island, though. Of course, the motherland. Happy to be here. Lots of people losing consciousness on the island, so I think it's a great topic to be covering right now. You know, reading through the objectives, the CCFP have made the perhaps fatal flaw of conflating the syncopal patient with the comatose patient. We're looking at a kind of mix of two things today we're going to be talking about. The first is, like I said, transient loss of consciousness, i.e. syncope and presyncope, and the other is the ongoing loss of consciousness, i.e. the comatose patient. Of course, these are both massive topics in their own right, and we're going to try and fit it into one episode today.
And even though you probably look at this and you go, oh, that sounds like an ER topic, it's clinic too. You'll have people constantly coming in saying, oh yeah, I kind of almost passed out yesterday and 3 days before that. And you have to have an approach to it, and you have to know what you're looking for. So syncope is massive in any setting for sure. There's also lots of next steps that you have to think about when you're in the clinic. Things like driving safety. When can they start driving again if they're going to, and how to help the patient go about avoiding having this happen again, or can they avoid this happening and otherwise just be safe when it does obviously happen again.
Exactly. And a lot of these investigations, while they may be started in the urgent care or the emergency department, oftentimes they're going to be started in the clinic as well. These are patients who you may not have a clear source of a syncope, and they might need a Holter monitor or maybe an echo. Or, you know, what about the patient who smacked their head? They get a concussion. How are we supposed to counsel these patients? This is actually a big part of syncope and loss of consciousness management for real life and for the CCFP objectives. So big things to cover.
And so in the true life of a generalist, there's lots to consider no matter where you're seeing these patients. Have a look at the CCFP objectives. We'll also highlight them throughout the episode, which ones we're hitting on, to make sure we're covering them all.
But before we do, let's just start with a definition, the first of which is syncope, which, as we all know, is a transient loss of consciousness and postural tone. It resolves spontaneously, and by definition, that patient should have returned to their baseline neurological function within seconds or a few minutes. Presyncope is very similar. It's that near loss of consciousness, but because of the way that it kind of works on the underlying pathophysiologic basis, we should be thinking about these the same way we think about syncope, because we know that they portend a similar risk of downstream badness. With that, let's go for it.
Objectives 2, 8, 12, and 13. As part of the assessment of a patient who has lost consciousness, get a focused history from the patient or witnesses, including duration, trauma, pre-existing conditions, drugs, toxins, medications, and seizure activity. And when following up with them, assess and advise regarding return to work, etc. And for patients who have had a loss of consciousness without clear diagnosis, go looking.
Let's say you, like myself, are currently working rurally in Port Alberni on Vancouver Island. So we're going to set the scene there. It is late November. You are working the early morning shift, and there is one patient in the wait room. You pick up the chart and read the triage note. This is a 17-year-old female. She fainted during a high school assembly. She struck her head. According to witnesses, there is maybe a loss of consciousness, about 15 to 30 seconds or so. You quickly review the vital signs. Triage vitals all look normal. She doesn't have any prior visits, nothing else on her chart. Bring her into the room. Caleb, what else are you looking for right now on history?
At first, I wanted to tell me about the episode. Does she remember it? What does she remember before and after? Was she having arm tingling? Was she running and jumping around the room? Was there any stress? Is she feeling unwell? Has this happened to her before? Any cardiac symptoms, so palpitations or chest pain, or is she exerting herself at the time? Probably go through Wells score items to be concerned if there's a clot that might be contributing. It's a she, so I'm asking around sexual activity. Is she sexually active? Is she using protection? Has she had recent AM vomiting? These sorts of things. And then the usual boilerplate stuff. Any family history of cardiac stuff or sudden death? Sudden death might look like as well a single car crash that seems mysterious. Nobody knows why they crashed, for example. Past medical history, any medications she's taking. Is she using non-prescription stuff? So injection drugs, smoking anything. And then other stuff like, did she bite her tongue, particularly on the lateral aspect? Did she wet herself? Any confusion, post-ictal state afterwards? Does she have have epilepsy? That'd be a big one. And then is there any trauma? Did she fall? Did she hit her head? Is her head sore, neck sore, any headache, vomiting, amnesia, mental status changes? That was a lot.
Wow, that was a lot. That was possibly the world's most thorough syncope history. And you hit on a lot of the major points there, right? So let's kind of go back to the case here. So to answer some of your questions, this was an early morning assembly. She skipped breakfast. She got there early. She was standing at the time when it happened. She'd been standing for about 30 minutes or so. It was a cramped gym, lots of students, very warm. She started feeling diaphoretic, a little bit nauseous, and as she describes, woozy beforehand. Apparently, a couple of her friends told her that she looked pretty pale. Next thing she tells you, she remembers she was waking up on the ground. According to her friend who was actually there with her in the emerge, she hit her head on the back of the gym floor. She thinks maybe about 15 seconds loss of consciousness or so, but she slowly started coming to afterwards. A couple of the teachers helped her up. They grabbed her and brought her over to the nurse's office. She was ambulatory and feeling fairly well at that point. They gave her a juice box. She was doing okay. Doesn't have any confusion persisting right now. Doesn't have any cardiac or respiratory symptoms either now or prior to or following the event. No DVT risk factors you think about, no medications she's on. She's sexually active with a single male partner. They use barrier protection. Last menstrual period was a week ago as she expected, otherwise no abnormal or unexpected vaginal bleeding. She's feeling well beforehand, like I said, and she's pretty much on your assessment telling you that she's more or less back to her baseline now. She's got a bit of a local minor headache where she struck her head, but otherwise no headache red flags, no vomiting, no neck pain, no confusion. Had one similar episode kind of like this in the past. This was back during her grade 6 vaccinations. She doesn't like needles. Otherwise, no past medical history, no medications, no allergies, and no family history of sudden or unexpected deaths.
Yeah, so obviously the thing that's jumping at you is vasovagal. She has a predisposition for it, but you still want to make sure none of that big scary stuff is in there. So do a proper physical exam, check the heart, check the lungs, look for signs of trauma to the head and neck. I usually look in the ears for the usual hemotympanum, postauricular ecchymosis, etc. Make sure her vitals are back within normal limits. In her case, I would still get a beta HCG for sure, and I do a cardiac workup, at least an ECG. But after that, it's kind of dealer's choice on whether you get any more investigations beyond that. The most likely thing in this poor gal's case would be discharge home, maybe follow up with her family doctor to see if there's any ongoing issues and make sure that she knows that she may have future falls and to be cautious around them.
Yeah, 100%. I think that counseling aspect is huge, and it's something we'll touch on a little bit later as well. I just want to dig into a few things that we mentioned on the history before because I think they're really important and they kind of inform the way that I approach syncope and presyncope myself, which is kind of this 3-step approach that I take. Step 1 for me is decide syncope or mimic. So like pseudosyncope, for example. Step 2, if it fits with syncope, what are the causes that I need to consider in workup? So is this a benign, very common vasovagal episode, very clear trigger, someone predisposed to it versus something that's potentially dangerous? Third step for me is disposition. Disposition is king here. So what is this patient's overall risk? How likely do I think this is to happen again? Are they safe to go home? And if so, do they need investigations? Do they need follow-up? And importantly, how do I counsel this patient? First off, let's start with step numero uno. Syncope versus mimic. Caleb, what's the big thing that you're considering here and how might you kind of make this distinguish?
Seizure is a big one. In this case, it's probably a little bit easier unless you're thinking absent seizure, but can be a lot more difficult than you might think to distinguish between these two, especially if it happened with nobody watching. The main things that we have some evidence for is looking for tongue biting, particularly the lateral tongue, but don't fall for the middle front end of the tongue because if anyone falls and hits their head, they can bite their tongue in a transverse fashion. So check out either side of the tongue. Look for incontinence, either stool or bowel. Again, there's some overlap there, so certainly if somebody has a syncopal event, they can lose their urine in particular. The one I really like is if somebody has watched it, it's the 10-20 rule. So if the people watching think back and they think, yeah, it's probably less than 10 of those myoclonic jerks after they lost consciousness, it's probably myoclonic jerks from syncope. Whereas if it's more than 20, it's probably more likely seizure. So it'll depend on the reliability of the bystander that saw it, but it's a cool rule to dig into when you hear these. If you look at one of the awesome EM cases on Syncope Simplified, and there's a good episode about that.
Speaking of mimics, the other big one is head trauma. This is this idea that you strike your head and then you lose consciousness. This is something that's less common in the younger folks, or at least less common in the sense that they would know if it happened. There would generally be a pretty good collateral, like I smacked my head really hard and then passed out. In older folks, it can be a little more challenging to tease that out. There's always this idea of which came first, the fall or the head hit. And, we're thinking of these mechanical falls. We're thinking of risk factors for falls. So a lot of those things that would be related to risk factors for syncope itself. We're going to be looking for signs of trauma. I think that's generally just a good practice for all syncope patients, but a thing to certainly keep in mind.
To the truth machine. All right. We've decided that it's not a seizure. We don't have any reason to believe it was a seizure, and it wasn't an accidental fall where they mechanically fell and hit their head. So we've decided syncope, pre-syncope. This is our second branch point. What caused their syncope? Give us an approach.
Classic kind of EM mindset. It's super relevant to the family practice office as well, is rule out the deadly stuff and then consider the common stuff. This is truly a chief complaint where it can be caused from anything from the most benign and common vasovagal syncope to things that are literally immediately life-threatening, and everything in between those as well. When you go online and you read textbooks and family medicine resources and whatnot, you're going to see this cardiac versus non-cardiac. And I think that kind of gets down to the crux of where we need to make this determination. But my specific approach is a little bit more broken down, just trying to remind myself of all of those things that can cause it. And so I like to think about the cardiac clots, bleeds, blood pressure, and brain. Okay, and this is my approach to syncope. Starting with cardiac, the big thing is rhythm versus structure. And so for rhythm, are they going too fast? Are they going too slow? Is this a dysrhythmia of some sort? Rapid runs of AFib or flutter or VT or some of those weird congenital QT syndromes that are kind of outside the scope of this podcast versus the structural problems. This is a thing like hypertrophic obstructive cardiomyopathy. That's this classic sudden death in a healthy young athlete, or really bad aortic stenosis. It's kind of logical to think about how both of those issues could cause a syncopal event because they're transiently blocking blood from getting to the brain. And on that topic, I like to think about clots as well. So that just reminds me to think about PE, which is technically a cardiac problem if it's causing you to syncopize, but in my brain, it makes sense just thinking about as clot as its own issue because it's one that we can forget. Hopefully with PE, it's not going to be an isolated finding, right? So they'll often hopefully have things like chest pain or dyspnea, DVT, PE risk factors, and probably some sort of a vital sign derangement, whether they're tachypnic or tachycardic or hypoxic. And then the other things, bleeds and blood pressure. Caleb, walk us through those.
Bleeds. If your pipes are getting emptied, you have a good chance of passing out because of it. It's transient, it's shock-like. Basically anything can cause blood loss. AAA's, GI bleeds, ruptured ectopics, etc., etc., etc. But just like PE, hopefully those are going to come with other features that are going to point you towards them. So it'll be a reproductive age female with abdominal pain or hematochezia for the person having GI bleed, and on and on. Next is blood pressure. This could be common orthostatic hypotension, often old folks who stand up too quickly, or it could be compensated shock. So maybe they compensate while they're lying down well due to their blood loss, dehydration, sepsis, etc. And then they stand up and they have a low blood pressure that transiently makes them pre-syncopize or syncopize. The caveat is that orthostasis itself is super common, but it isn't always benign. So it could be a symptom of something else. So don't forget your hypotension differential.
Yeah, and that leaves us with brain. So that kind of reminds me to think of the most common and thankfully most frequently most benign causes of syncope, which is vasovagal. This is something that is regulated by the autonomic nervous system, and it's the most common by far reason we see for syncope. So about 20% of emerge visits plus or minus. And that's this typical expected prodrome that we see. They're diaphoretic, they're nauseous, they're pale. Many of us have experienced this before, right? This is maybe you're in a hot OR and you're getting pimped by the surgeon and you start feeling lightheaded and need to take a step back. You're standing in a hot room. Maybe you're getting sutured by a first-year medical student. They forgot to put local anesthetic in. All of these sorts of things are going to make you want to pass out, and you're going to know that you're going to pass out before you pass out. There's a clear trigger. Other triggers we're thinking of like urination, bowel movements, right? Valsalva maneuver. It's classic for these older guys with BPH. They get up in the middle of the night, they take a pee, they're straining a lot and they pass out. Those are similar mechanism to vasovagal and similar with carotid spotted sinus hypersensitivity. So this is the classic, you're shaving, then you syncopize. Those are things that we want to think about as triggers as well. And then brain is also reminding me once again to make sure this isn't a seizure. And then there's the other intracranial stuff, right? The subarachnoids and the TIAs, and those can present with syncope too. But of course, that won't be in isolation in 99% of the cases. And you really should see other stuff associated with those as well. And then as a final bottom of the barrel rule out, could this be a psychogenic pseudosyncope?
All right, that's tons of differential. Now we need to figure out how we're going to distinguish between all of these, and history's king. It's got to be, because we don't have much else to go with. The low risk features that we already mentioned are things like if there's a classic prodrome, they can feel it coming on. If there's a stressful trigger, we're into vasovagal town. For high risk stuff, that cardiac clots, bleed, BP, brain, most of these are probably going to have clinical features that are going to zero you in on one of these. So syncope plus is what we can think of. So syncope plus abdo pain, syncope with chest pain, syncope with palpitations, and on and on. So remember, cardiac syncope is cardiac until it's not. You're thinking of rhythm or structural problems. These are the big killers. So you need to rule out those arrhythmias or hookums. And some important things that are concerning for cardiac when we're talking about history. So if there's no prodrome and they just passed out, or if there's palpitations, chest pain, or feeling short of breath, or especially for kiddos, if it happened during exertion. So exertional syncope is a bad one. They're hanging out with you overnight until they can get an echo and see cardiology. And then past medical history wise, if they have any known cardiac disease, your radar is going to be way up. You're thinking of things like AFib, aflutter, pacemaker concerns, family history of sudden death like we talked about. And the one to add on, so I talked about if somebody had a single car crash, no obvious reason for it, and died from that. The other one is drownings in young people. So somebody just drowned even though, as far as we know, they could swim fine and nothing untoward was happening at the time. And from a cardiac perspective, asked about meds as well. Antihypertensives are a big one, but anything that could vasodilate or slow your heart down could contribute to this.
Thinking about the big, risky, scary things, mostly all related to the heart. That means investigation-wise, every patient who presents after a syncopal or pre-syncopal episode is probably going to get one thing. And that one thing is C1 esterase inhibitor level.
Of course,
you got to get it. You got to rule out hereditary angioedema causing a transient hypoxic episode, right?
It's not a send out in Port Alberni, is it?
No, definitely. We do them in-house here.
Yeah.
But no, we're talking about ECG, of course, right? Except maybe the person who very clearly vasovagaled right in front of you. Pretty much every person who waltzes into the ED or the urgent care, even the family clinic with the syncopal episode, should be getting an ECG at some point. There's lots of things that we look for in the ECG, and you'll go on these lists on websites and you'll see long QT and short QT and Brugada and the VTs and the SVTs and the fibs and the flutters. I think the big summary here today is that normal sinus rhythm is good and pretty much everything else can range from possibly bad to very, very bad. One little pearl in the modern era is checking out people's wearables. A lot of people have an Apple Watch or similar nowadays. And what else are we maybe going to be thinking about considering in the ED or urgent care, wherever else we are, Caleb?
Your suspicions should guide you as you do with anything because you're a doctor. But CBC, if you're worried about anemia or infection, you'll get a basic lights and or extended lights. If you're worried about electrolyte disturbances, consider renal function as sort of your basic workup. Reproductive age females, beta HCG, gotta do it because we're thinking of things like ruptured ectopics, etc. Anything past that, it's patient specific. So ECG if you're worried about a cardiac contribution, and troponin as well. Septic workup if you think that's the case. You want a dimer and or just straight to CTPE if you're suspicious of a clot in the lung vasculature, and CT of the brain based on other episodes we've done. And for good measure, we did pop in the etiology table from Tintinelli's because it's sort of the realm of emergency medicine for you keeners that want to get into more detail.
And yeah, like we said before, vasovagal being the most common. I actually lied to you. If we were to look at the Framingham Heart Study, the most common source of syncope is unknown, everyone's favorite. But cardiac is up there, 10% according to that study. So that is not a trivial number. The other piece of that is the consequences of syncope. So what happened after the patient fell? So that's signs of trauma, especially to the head and the neck. And that's really just going to rely on a thorough exam as well, of course, as your history. And this, in fact, makes up 2 of the 11 CCFP LOC objectives. I'm just going to read them again because they basically explain themselves. In a patient with loss of consciousness and a history of head trauma, rule out intracranial bleeding. And in a patient with loss of consciousness who is anticoagulated, rule out, you're never going to guess, is intracranial bleeding. Who would have guessed?
Let's zoom back to the case that we were talking about before. You're a young person in the ER. Vitals are normal. Your exam of the cardiac and respiratory systems are normal. A little bit of tenderness to the back of the head where she hit the gym floor. There's no bleeding, deformity, or swelling. There's no other trauma to the head, scalp, neck, etc. You did get an ECG. It showed normal sinus rhythm at 74 beats and none of those funny nitpicky things that we worry about. She's feeling well. She's at her baseline, ready to send home with a diagnosis of vasovagal syncope. What should we tell her before she goes? Objective 9. When following up patients who have lost consciousness and there's potential for recurrent episodes, discuss specific preventative and protective measures.
This is safety counseling. This is important. This is regardless of the setting you're in, emergency, urgent care, clinic. Let's talk first about vasovagal. What are some of the things that we're going to counsel people on after they've had a fairly simple or straightforward vasovagal episode? So number one is going to be trigger recognition and avoidance if possible. Of course, that's not always possible. And so our next step is going to be counseling on what to do if those symptoms recur. That's going to be something like lying down and elevating the legs as a way to kind of restore some of that blood flow to where it needs to be. There's also these described counter pressure maneuvers that you may have heard of, things like tensing your arms with clenched fists, leg pumping, leg crossing. And the idea is basically the same, trying to push some of that blood back up into the brain where it belongs. And that might be able to stop a vasovagal episode or at least delay it long enough so that they can lie down and get their feet up. The next thing we're thinking about is orthostatic. So how would we counsel these folks if we're presuming this is an orthostatic episode? Similar things to above, but we're also thinking about what can we do with preventing all of that blood from pooling in the first place. So things like compression stockings, again, contracting the leg muscles, especially before standing. And I think one of the more important things as well is this slow to stand, right? So standing up in stages, going from lying to sitting. And then once you've been sitting for a couple of minutes, then stand up. And then of course, the usual, stay hydrated, consider increasing your sodium intake, especially if you're a tea and toaster or you have a baseline really low blood pressure. And then next is, what if we don't know what caused the syncopal episode? So how do we counsel these patients?
That can't happen. We're too smart. We always know. Objective 11 and 7. Advise the authorities about appropriate patients with loss of consciousness regarding driving status, and when following up patients who have lost consciousness, assess and advise regarding return to work, etc. A few things about these folks. First thing, disposition. Are they staying around on telly or are you sending them home? That depends, of course, on the overall risk assessment, plus the likelihood that this was cardiac or medical cause. It is hard to predict. There's some scores like the Canadian Syncope Risk Score. I used to use the San Francisco Risk Score, and then I was in South Africa working, and they go, "You've got a Canadian Risk Score. Why aren't you using your own score?" And then I think I looked into it, and it was quite well validated, and so I've switched over to the Canadian Risk Score. This score, there'll be an image from MD Calc on it, but basically it's looking at things primarily cardiac. So it's looking at heart disease history. They have a low blood pressure or high blood pressure at base, troponin elevated, long QRS, etc. So have a look at that, know it. It's pretty helpful. Second thing is driving and risky activities. So like swimming anywhere where they could drown or if they could crash, those kinds of things that you should think about. And then the Canadian Medical Association Driver's Guide, which is referenced here, as well as the Canadian Cardiovascular Society, their guidelines are the same. So pick one and know it. And then hopefully your patient does adhere to this. If you're worried that they might not, then you're certainly going to have to report it to your local driving authority. Driving's the obvious one, but think of other high-risk activities that may need to be held off on while they're getting their workup done.
In terms of driving restrictions, we have different recommendations from the Canadian Cardiovascular Society based on the type of syncopal episode that it was. And so Caleb and I will go back and forth, give you a few different types of syncope and the respective driving restriction recommendations. Caleb, why don't you start us off?
one episode that you are pretty sure was vasovagal.
Right. So this is going to be no restriction, thankfully, because that would be a lot of people, I think, who would not be driving. The caveat is that if this occurs in a sitting position, or maybe while driving, or perhaps if there was a very brief prodrome, which would basically not give them any time to pull over if it were to happen again.
Okay, what about if you diagnose the cause and it's appropriately treated?
In this case, the recommendation is to wait 1 week until there's no recurrence, and it's a month if you're a commercial driver.
All right, what if it's a reversible cause? So they had a hemorrhage and you seem to have gotten the bleed under control and it's stable.
Once you've gotten the bleed under control, things are stable. Using this as an example, they're able to drive essentially right away, assuming there's no persistent sequelae or consequences of whatever that reversible cause was.
What if it's situational and you have a pretty good obvious trigger for it?
You just wait 1 week with no recurrence.
So they can't pee while they're driving.
No peeing while you're driving, and if you do, you gotta Foley yourself and then drive. It's the only way.
Nice. How about one episode that we don't know what caused it, or they had multiple vasovagal episodes?
If you are a regular old driver, you got to wait 1 week. And of course, this is waiting 1 week without having an episode. If you are a commercial driver, though, you've got to wait a full 1 year. That is a big difference between these two. And again, this is for a single unexplained episode or multiple vasovagal episodes.
How about if they syncopized in the last 12 months multiple times, and so far we don't know why?
So you got to wait 3 months. And if you're a commercial driver, it's also 12 months. We need autonomous vehicles. That's what we need.
Objective 10. In patients with loss of consciousness following head trauma, treat and follow up according to current concussion guidelines.
What about concussions? This is objective 10. We want to treat and follow up per concussion guidelines. This is actually the only time that concussion gets mentioned anywhere in the 105 topics. So I think an important thing for us to touch on here today. This is more applicable, as you might imagine, to the head trauma leading to a loss of consciousness as opposed to a syncopal episode itself. But it can happen either way and really depends on the mechanism and the degree of head trauma from the episode. Of course, concussion is a very big topic, and so it's important that we're covering it here today, but it's only one of the objectives, so we're just going to touch on it very quickly and give you some resources where you can read up on this further. And I think a lot of us will already have a fairly good baseline understanding of how we treat concussions. So the definition, as you might imagine, is fairly nebulous. It doesn't require any imaging, but this is defined as a minor TBI or minor traumatic brain injury, GCS 13 to 15, measured at about 30 minutes after injury. Of course, that includes 15, right? So they could be perfectly normal, and in most cases they will be. That's these classic symptoms: headache, concentration and emotional impairment, brain fog, balance and vestibular issues. A lot of these start to manifest in the weeks after a concussion. It can take time to heal, and then it can't really be rushed. And so there's a few important things that we need to counsel the patients on. One of those, and probably the most important, is the red flags and expected course of symptoms. So not only are we telling them about all these concerning things that would warrant them coming back for an assessment, but the things that they could expect to happen. Because if you have no idea that you're still going to be experiencing brain fog and difficulties concentrating and headaches in the next couple of weeks, that could be a scary thing to have to go through. And so I always like to discuss this with patients at the bedside, but of course their brain's been bruised, so they might not remember it. And so I'll make sure to discuss it with someone who's at the bedside with them, and almost always provide them a handout on concussion. Concussion is one of the ones that I always try and give patients a handout for because there's lots to remember. I like the one from parachutecanada.org/parachute.ca. It's a great resource. It's got tons of clinician and patient resources for both recognition, diagnosis, and management of concussions. And then the next step we're chatting with them about is follow-up. These patients should be following up closely in a clinic, usually about 48 hours or so after the injury, and then regularly per the symptoms. This is also a great place to involve allied healthcare and other resources depending on the city you're in, you may have access to multidisciplinary concussion management programs. And so those are good things to look into and be aware of. And then the mainstay of treatment that we have for concussion is this return to activity, return to work, return to school protocol. It can get a little bit in the weeds, but from a Coles Notes perspective, the general idea here is that this is a graduated and stepwise return to activity. And so you go through stages, about 24 hours in each stage before you move back up to the next stage. So that would be like a short day at school and then a little bit longer day at school if you're able to tolerate it, and you continue to work your way up. If at any point you're having issues with the stage that you're at, you jump back a step and you go back to the previous stage. Some of the traditional teaching has been that prior to going back to school or activity in the first place, we advise a couple of days of rest, but this has actually been challenged by a few different research papers, and now the recommendations are actually starting to change, and we know that there can be improved outcomes if you start light exercise early, i.e. within 2 days of the concussion, of course as tolerated by your symptoms. But these are good things to be aware about and good things to counsel your patients on.
Objectives 1, 3, and 6. In an unconscious patient, assess the ABCs, resuscitate as needed, examine the unconscious patient for localizing and diagnostic signs, and assess and treat unconscious patients urgently for reversible conditions. This is different than your syncope approach. Kind of odd that they're both together, but c'est la vie. So think of it like altered mental status, not syncope. We're kind of in a new category here. First thing, of course, ABCs and DEs, and resuscitate as necessary. It's pretty straightforward. So the empiric thing for all these obtunded patients is start a movie, just as we have before in our resus episode or whatever it's called. So this is get them on monitors, give them some oxygen if needed, get a set of vitals and repeat them to make sure they're stable, get an IV or two, and get an ECG. Those ABCs have been beaten into our brain. If you want to further beat your brain, add D and E, which is disability, and dextrose. DEFG, don't ever forget glucose. Pupils is your disability as well as GCS. And then for E, it's exposure. So get them totally exposed, clothes off, get them in a gown after that. You're looking for traumas, you're looking for bruising, you're looking for evidence of drug use, any pain med patches. So if they've got 12 fentanyl patches on, medical bracelets, or any sources potentially of infection.
Love it. And Caleb, once that's done, the big question is, of course, why are they obtunded? This may be the longest differential diagnosis in medicine. Caleb, I'm not sure if you can think of one that has a longer differential than altered mental status, but I think this one takes the cake. Fatigue, NYD, of course, possibly, but scan them, the donut of truth. But really, I think the best way for this is breaking it down into a nice organized approach for differential diagnosis. You may see the AEIOU tips. I don't really love that one because it's so many letters, and DIMES has been my go-to since day one of medical school. We're going to briefly go through each of these in the DIMES mnemonic and cover a couple pearls and pitfalls for each of them. And so starting off with D for drugs, we're going to be reviewing the patient's drug list. Is there anything that could potentially predispose to overdose or causing severe side effects? May grab a serum tox panel, so the salicylates, Tylenol, ethanol. Don't forget about opioids. This is a clinical exam. Give naloxone if you think it's there. And then other things, benzos and ethanol, are also high yield to be thinking about in this category.
And then I, of course, is infections. So meningitis, encephalitis is a big one, but also it could be quite a severe sepsis. So think of your respiratory, urine, derm, blood, bacteremia. Think about your SIRS and your source. Do a thorough exam for any evidence of these infections. Although if they're obtunded, good luck. Get a whole bunch of blood work, get a culture cooking, get your urines going, maybe get a chest x-ray. If they're not waking up despite a better cause, then you're probably going to have to go grab some CSF off them. Of course, you include all your other sepsis labs.
Metabolic. So is this an electrolyte problem? There's a lot of electrolytes, as I've since learned, but the big ones we're thinking about today, sodium, especially hyponatremia, potassium, especially hyperkalemia, and calcium can cause things as well. We're thinking about that in the renal patients, especially. Also thinking about ethanol. High ethanol use can cause electrolyte disturbances. Alcohol is a potent disturber of electrolytes. Thinking about malignancies, those can as well. And then other metabolic things, liver failure. Do they have known liver disease? thinking about common causes of acute liver disease, acute liver failure. So the viral hepatitis and Tylenol. And then if they have known liver disease, things like hepatic encephalopathy. Coming back to glucose, blood glucose, don't ever forget it, especially if it's too low. Remember A, B, C, D, E, F, G. Don't ever forget glucose. And of course, thyroid sometimes as well.
E is environmental or potentially endocrine. Some people add that in there for the thyroid and etc. Environmentally, you're thinking of stuff like, were they in an area where they could have been breathing in carbon monoxide? If the dog is also getting a headache and sick, maybe you have to be suspicious of it, especially if they feel better when they've left that area. Do they use wood fire heating at home? Is there a risk of hypo or hyperthermia or clinical evidence of the same? Then correct that. And primary psychiatric stuff is going to be a diagnosis of exclusion.
Nice. And then finally capping it all off, S for structural. I think of this maybe a little differently than other people do in the past. Typically you hear just the head for structural, but I like to think of any structure in the body. So head, heart, lungs, pipes, GI, GU. And so for the head, is this a stroke? Is this a bleed? Is this a seizure? Encephalopathy? Question. Answer is CT head, usually. Heart. MI, arrhythmia, thinking about things like your ECG, your troponins, maybe bedside ultrasound if you're good at it. Moving our way down to the lungs, could this be respiratory failure? Hopefully you should have some clear vital derangement that suggests that, but getting, of course, peripheral O2, getting a blood gas if you need it. And then the pipes, the blood pressures. This is the obstructive, distributive, hypovolemic, cardiogenic, our shock differential, thinking about that as well. And then GI and GU, this just reminds me, urinary and stool retention, particularly in older patients, people with a history of dementia. These can be more common than you think as a reason for altering someone. You would probably be altered too if you hadn't pooped in 6 days.
Mm-hmm. And for the Keeners, again, Tintinelli's table for quote unquote coma, another approach, another way of looking at that differential if that's your preference. That was big.
That was huge.
Syncope. Think of cardiac stuff, clots, bleeds, blood pressure, and brain. The big one, of course, for syncope is it's cardiac until you can show us that it's not cardiac, so everyone gets an ECG. If it's low risk with a clear trigger, they can probably go home. Remember all your counseling advice with them because they should bounce back if they need to. If there's no clear trigger or if you're worried it's bigger risk, then you may have to admit them for ongoing workup or just monitoring on tele and consider Holter for arrhythmias. Remember your driving restrictions. If it's vasovagal, probably nothing unless it's recurrent without a clear trigger, and all the rest have recommendations from 1 week to 1 year. Look at the driver's guide referenced.
Yep. We also covered concussion. We're thinking about those red flags, what requires imaging. If none of those are there, it's a clinical diagnosis, but make sure that you are counseling patients and refer them to your preferred local resource. And we're giving them return to ED precautions as well.
And then we had the unconscious patient. It's not syncope, it's altered mental status and or coma. ABCDE, start a movie, check your sugar always, do a thorough head to toe looking for signs of trauma, stigmata of liver disease, blown pupils, signs of infection, etc.
DIMES, drugs, infection, metabolic, environmental, structural, and base your investigations on that cause. The sicker they are, the more they're going to get, but the minimum is usually broad blood work, serum tox, infectious workup, CT head. Take it from there. Caleb, I think with that, we're done.
Huzzah! Thanks so much for coming back to make this episode in your very, very busy year.
Happy to do so. I think it's another high yield topic.
Yeah. And check out that EM episode of Syncope Simplified. It was honestly absolutely clutch. They really dialed it in there.
With that, Caleb, I think we're done. I will see you again very shortly.
Bye, everyone.